So welcome everyone to the lecture on geriatric emergencies. So today we're going to be talking about old people, so we're going to be talking about Raymond. So take your book, turn to chapter 35, page 1283. And looking on the introduction, it says geriatrics is the assessment and treatment of disease in a person who is 65 years or older. And they present as a special challenge for healthcare providers because the classic presentation of injuries and illnesses are often altered by the presence of chronic conditions, multiple medications, and the psychology of aging. All right, moving on over to geriatrical considerations. It is important to understand and appreciate how the life of an old person may differ from yours. It takes time and patience to interact with an old person. So have patience and treat the patient with respect. Also, make every attempt to avoid ageism, which is a stereotype of older people that often leads to discrimination. All right, turn on page 1284. Communication and older adults. Effective verbal communication skills are essential to the successful assessment and treatment of older patients. The aging process brings with it changes in vision, hearing, taste, smell, touch, and pain sensation. Changes in communication abilities accompany aging such as dementia and other diseases. And your first words to the patient and attitude behind them can gain or lose a patient's trust. So when you speak to an older person, always speak with respect. All right, and looking under communication techniques, I want you to look at where it says when you interview an older patient, the following techniques should be used. All those are very important, but two of them I want you to pay close attention to are where it says look directly at the patient eye level and ensure good lighting, and have one person talk to the patient and ask only one question at a time. So go ahead and highlight those two things. Then we'll move over to common complaints and leading cause of death in older people. The changing psychology of geriatric patients can predispose this population to a host of problems not seen in youth, such as a simple rib fracture in an 80 or 90-year-old can result in pneumonia or even death. Or even a hip fracture from a low mechanism fall is common in older people, and it may have dire consequences. Sedentary behavior while healing after a fall can predispose the patient to pneumonia and blood clots. All right, so looking at over on page 1285, table 35.1, common conditions and leading causes of death. Go ahead and highlight those two things, primarily the leading causes of death. All right, we'll move on down to changes in body. The bottom of page 1285. Human growth and development peaks in the late 20s and early 30s, at which point the aging process begins. The aging process is inevitable, accompanied by changes in psychologic functions such as decline in function of liver and kidneys. Also, metabolism slows down. There's a decrease in food intake, and that is because of the lack of blood clotting. There's a decrease in healing, which can lead to infection. Decreased immune system makes older people susceptible to disease, and they also have a loss of balance. Why? That is because their brain shrinks as they age, and they are also weaker due to muscle loss. All right, page 1286, changes in the respiratory system. Looking under anatomy and physiology, we see that age-related changes can predispose an older adult to respiratory illnesses. Weakening of the airway, musculature can cause decreased breathing capacity. Villi can become large and elasticity decreases, making it hard to expel used air. Chemoreceptors slow with age, causing the body to respond more slowly to hypoxia. And looking at the last paragraph under anatomy and physiology, go ahead and highlight that. All right, moving on to pathophysiology, pneumonia. Go ahead and highlight the definition of pneumonia, which is basically it's an inflammation, infection of the lung from bacterial, viral, or fungal causes. It is the leading cause of death from infection in Americans older than 65 years old. The signs and symptoms of pneumonia include greenish yellow mucus, fever, shortness of breath, and rapid shallow breathing. All right, then we have what's called pulmonary embolism. It is a condition that causes a sudden blockage of artery by a venous clot. A patient with a pulmonary embolism will present with shortness of breath and sometimes chest pain. Thus, it can be confused with cardiac, lung, or musculoskeletal problem. Causes in the geriatric population include living in a nursing home, recent hospitalization for medical illness, surgery in a lower extremity, history of blood clots, a paralyzed extremity or extremities, obesity, and sedentary behavior after surgery. So if you look at under pulmonary embolism, the definition of a pulmonary embolism, and where it says the patient with a pulmonary embolism will present with shortness of breath and sometimes chest pain, go ahead and highlight that. And under the second paragraph, where it starts with patients present with tachycardia, sudden onset of dyspnea, and shortness of breath, go ahead and highlight that paragraph there. And we'll move on to changes in cardiovascular system. Under anatomy and physiology, the heart hypertrophies, which is usually a response in chronically induced afterload imposed by stiffened blood vessels. Over time, cardiac output declines, mostly a result of a decreasing stroke volume. And looking at the definition of arteriosclerosis, go ahead and highlight that, which is arteriosclerosis is basically the hardening of arteries, and it contributes to systolic hypertension, which places an extra burden on the heart. All right, and moving on over to pathophysiology, page 1287. Geriatric patients are at risk for atherosclerosis, which is basically accumulation of fat and cholesterol inside arterial walls. And you'll see that definition in the second paragraph. Go ahead and highlight that, but make sure you don't get those two, they're confused, because they look up, the spelling is almost identical. All right, and atherosclerosis makes stroke, heart disease, hypertension, and bowel infarction more likely. And the blood vessels themselves become stiff, which results in higher systolic blood pressure. The electrical conduction system of the heart undergoes changes leading up to abnormal heart rates and rhythm. All right, so now we're going to talk about orthostatic hypertension, which is the third paragraph, or second paragraph from the top on page 1288. Orthostatic hypertension is basically a drop in blood pressure with a change in position. Anytime we have a patient who feels dizzy when they stand, or lightheaded, or if they have a syncopal episode, which is basically where they pass out or faint, we do what's called a tilt test, and it can help determine the patient is hypovolemic. So basically the way we do the tilt test and check for orthostatic hypertension is, first off, we have the patient lie down. So when the patient is lying down, we check the patient's blood pressure, and then we check the pulse. We wait 1 minute. We have the patient to sit up, whether in a chair or side of the bed. We check their blood pressure. We check their pulse. Wait another minute. Have the patient to stand up. Then once again, we'll check the patient's blood pressure, and we'll check the patient's pulse. If the pulse rate increases by 20 or more beats per minute, and the systolic blood pressure drops by 20 millimeters within 3 minutes of the patient rising, the person is said to have orthostatic hypertension. That tells us that this person is dehydrated or something else is going on. Venous status can cause clots to develop in veins, leading to deep vein thrombosis or a pulmonary embolism. Loss of proper function of the veins and legs that would normally carry blood back to the heart. All right, and moving on down to a myocardial infarction, which is basically a heart attack. The classic symptoms of a heart attack are often not present in geriatric patients. Why? Because geriatric patients do not feel pain like younger people do. All right, moving over, we have heart failure, and which you've talked about heart failure in the past, so I'm just going to kind of refresh your memory. The signs and symptoms will differ depending on the extent to which the right or left side of the heart is not functioning correctly. Right-sided heart failure, if you remember, is when blood backs up in the body. And the signs and symptoms of right-sided heart failure include JVD, ascites, and peripheral edema. And you'll see that under heart failure, second paragraph. Go ahead and highlight that. All right, and also highlight where it talks about left-sided heart failure, which is basically when blood backs up into the lungs. This causes pulmonary edema and shortness of breath. All right, and we have what's called paroxysmal nocturnal dyspnea, which is characterized by a sudden attack of respiratory distress that wakes a person at night when he or she is reclining. The common cause include fluid accumulation of the lungs. Now, signs and symptoms of left-sided heart failure include coughing. They feel like they're suffocating, cold sweats, and tachycardia. So, highlight the bottom part of underneath heart failure, where it talks about left-sided heart failure, all the way to the paragraph 1289, and the next to the last paragraph. All right, so now we're going to talk about strokes. Stroke is the leading cause of death in older people. Preventable risk factors include smoking, obesity, and sedentary lifestyle. Uncontrollable factors include age, race, and gender. So go ahead and highlight those. That's on the bottom of the paragraph under stroke. All right, so two kinds of strokes that you need to be familiar with and know the difference between. The first one is what's called a hemorrhagic stroke, and that is when a broken blood vessel causes bleeding to the brain, and they're less common but more likely to be fatal. And then we have what's called ischemic stroke, and that occurs when a blood clot blocks the flow of blood to a portion of the brain. And if you'll look on page 1289, the first and second paragraph, go ahead and highlight those two paragraphs. And you always want to determine when the onset of symptoms started, because that is very important. If the symptoms occur within the past few hours, the patient will be a candidate for a stroke center therapy. And we also have what's called transient ischemic attack, which is basically a TIA. That is, or more commonly called TIA, which is basically your body's way of warning that you're about to have a stroke. It can present with the same signs and symptoms of a stroke, but it usually resolves itself in 24 hours. But we always want to manage as if he or she is having a stroke. All right, page 1290, changes in the nervous system under anatomy and physiology. Changing in thinking, speed, memory, and posture stability are the most common normal findings in older people. The brain decreases in terms of weight and volume as a person ages, increasing the amount of space in the cranium and chance for head injuries. There is a 5 to 50% loss of neurons in older people. This affects the control and rate of death of breathing, heart rate, blood pressure, hunger, thirst, and body temperature. That's why old people are cold all the time. The performance of most of these sense organs declines with increasing age. All right, moving on page 1290 under vision, go ahead and highlight the definition of cataracts. Cataracts can also increase the likelihood of fall and medication errors. Then under hearing, changes in the ear can cause problems with balance and make falls more likely. Hereditary and long-term exposure to loud noises are the main factors that contribute to hearing loss. And under taste, the sense of taste can be diminished because of decrease in the number of taste buds, which can lead to lessened interest in eating. And under touch, an older person may have a decreased sense of touch and pain perception from the loss of the end nerve fibers. An old person may be injured and don't even know it. And there's also a decreased sensation of hot and cold. All right, pathophysiology under dementia. Dementia is a slow onset of progressive disorientation, short attention span, and a loss of cognitive function. So go ahead and highlight the definition of dementia. And also highlight where it says dementia develops slowly over a period of years rather than a few days. And also highlight where it says potential causes include Alzheimer's disease, Parkinson's disease, cerebral vascular accidents, and genetic factors may also cause dementia. All right, bottom of page 1291, delirium. It is a sudden change in mental status, consciousness, or cognitive process. It is marked by inability to focus, think logically, and maintain attention. So go ahead and highlight that. And it is usually a result of a reversible physical ailment such as tumors or fever, dehydration, or side effects. All right. Turn on page 1292 where it talks about urinary tract infections or UTI. Go ahead and highlight that. And also highlight where it says hypoxia, assess the patient for the following specific condition that can be managed at the pre-hospital level: hypoxia, hypovolemia, hypoglycemia, and hypothermia. Go ahead and highlight those. All right, and moving on down to syncope, which is basically fainting. Always assume that this is a life-threatening problem until proven otherwise, and syncope is also often caused by interruption of blood flow to the brain. So go ahead and highlight that underneath syncope. And we'll move on to neuropathy, which is basically nerve pain. And it is basically a disease of the nervous tissue that result of damage or malfunctioning nerves. So go ahead and highlight the definition of neuropathy. And we'll take a quick break and I will be right back.